I'm Maria Crotty. I'm the Professor of Rehabilitation and Aged Care at Flinders University, and I'm a member of the NHMRC Cognitive Decline Partnership Centre, and our group did this project which looked at two models of residential aged care, cluster models and conventional models. And what we were looking at was the outcomes, the resource use, the costs of these two different models. So the cluster model has had a lot of publicity. It's very popular with consumers. It's big in the US. There's a model called the greenhouse model. And the model is small, domestic, less than 15 people. Usually the model of residential aged care has the kitchen inside that cluster and the residents can prepare their own meals. We recruited 17 facilities from 4 states, and we consented 541 people. We then asked those people if we could have all their PBS and MBS data about the way they were using drugs and hospital visits and GP visits, and then we compared the two models. And what we found was that the people who lived in the cluster models had reported better quality of life, they reported better quality of care, they were significantly using hospitals significantly less, about 70% less, they're turning up at ED less, they were less likely to be on a psychotropic drug. So we then dealt with the issue of, well, maybe it's quite expensive to run these models, but we looked at the books of all these organisations, all these aged care facilities, and we couldn't see any difference in the running costs between the two kinds of models. And when we actually adjusted for the complexity of the people who are in those different aged care facilities, the cluster model looked a bit cheaper. It looked to us like someone who was in a cluster model, if they'd been in a conventional model, they would have cost about $12,000, $13,000 more to look after. It's actually very difficult to improve the quality of life of people who live in residential aged care and have dementia. It's hard to find ways to do that. The government's spending about $12 billion a year on aged care. A little bit of that is on regulatory approaches to try and make sure that quality is okay. I think if we had a drug that we knew was improving quality of life, we'd be very interested in it. What we've got here is an environmental approach, a model of care which appears to produce a different and a better quality of life. So I think it requires more investigation. We're not really sure why the quality of life was better in these small models, cluster models, than in conventional aged care. It may be that people were more activated and socialising more, but that's speculation. I think our study has shown what a lot of people believed anyway. A lot of people believed these models were better, but what we showed was that they produced better reported quality of life. So we did include people's reports, and I think we didn't find that it was any more expensive.